Good morning and welcome to Coloproctology 2021. This year, as you all know, the theme is looking inward. When you manage a retracted stoma, you have to look inward to see what is it. And of course, using convexity is one of the options. And this topic today, I will be sharing with you some of the optimization of convexity used in retracted stoma. Let us look at some of the areas that will be covered. First is to introduce to you what convexity is, why convexity, and its indication. Also will be discussed will be selection of convexity and accessories. Also some of the clinical cases that I have managed earlier. Now, if you have a patient with retracted stoma, usually a convex skin barrier is required. The picture here shows a convex skin barrier. When you overturn it, it is actually a dome-shaped appliance that is quite similar shape to this dome-shaped structure. The purpose or the function of it is to apply gentle pressure onto the skin surrounding the stoma. That is what we call the peristoma skin, and also this way it allows the stoma to protrude so that the output that comes out from the stoma opening will go into the pouches or the ostomy pouch directly. Now, why need convexity? Usually, convexity is used because we need a good appliance seals. And a good appliance seals depends on a few things. First is the contact between the peristoma skin and the skin barrier. The skin and also the skin barrier, yeah? And of course, the adhesive material will do a part. But most importantly will be other factors such as the skin surface. Example, if you look at this picture here, the stoma is actually sunken, not sunken, but the skin outside here, the skin, there is some folds here, there's some suture line here, so which make the adhesive a bit more difficult to fit in, yeah? So with this, sometimes if you are using a skin barrier that is flat surface, it may cause leakage from the side here, left and right as well. Because when the patient lying down, you can see it is already sunken in. What about if the patient is sitting up? The fold will be even deeper, and then the leakage will be easily come out to this side and the skin barrier will not last. Besides skin surface, we also have to look at the abdominal surface. Example, this abdominal surface is quite firm. Whereas if we have got a patient that is with very flaccid abdomen or very a lot of skin creases, then it is not so easy to manage as well. Convexity becomes very handy if you have a patient that is with multiple skin fold. Of course, another very important area will be the stoma protrusion. We will have to look at the how long is the stoma. Of course, again, depends on the type of stoma. If it's ileostomy, naturally need to be a bit higher because the output is more watery, and when the output is more watery, the pouch-like stoma will allow the fluid to drain directly into the bag, whereas the colostomy with firm stool, that is not so important, but at least they must have at least about half an inch above the skin level. And this patient here is having a stoma that is same level or below the skin level, which is more difficult to manage. On top of that, the stoma opening position, it is also not ideal because it's actually pointing to the skin level. So you can imagine the difficulty to manage this patient, yeah? Sometimes the stoma opening is facing the top of the skin. It is not below. It is also another type of case that is more difficult to manage. Now let us look at other areas of convexity. So with a skin barrier that is not so fitting well, these are the consequences. the leaking will become very frequent. So whenever there's leaking, if they don't change, they will have skin excoriation. If they change, they have to change very frequently. If they don't change, the output staying on the wafer or the skin barrier will cause odor and skin excoriation. When excoriation happens, then the vicious cycle starts. When there's skin excoriation, the skin is no more there. It is the skin is rubbed off already. So when there's no skin, it is even more difficult to allow the skin barrier to stick on the peristoma skin. So all this can actually cause the patient to feel very depressed, and sometimes they isolate themselves because of the situation that is uncomfortable for them, leaking, odor, and also painful because of the skin excoriation. Now, some of the indications for the convexity use is here. When you have a retracted stoma like this, or even sometimes flush stoma like this, there is an indication to use. However, sometimes even not retracted stoma like this one here, somehow the surrounding skin is a bit sunken in. Even though the stoma is well protruded, but the surrounding skin is sunken in, it will make the management very difficult. Another condition is when the patient having a protruding stoma, although it's not very well protruding, it's moderately protruding, but the difficult part is the opening of the output comes out under the skin because the opening is pointing to the skin. So this kind of stoma opening will also cause a lot of problem. Just like the patient in this picture here, she go through a lot of pain, a lot of difficulty to manage, like changing every few hours the skin barrier. At times you have got all nice stoma. Somehow the patient is having very flaccid abdomen, a lot of skin fall. When the patient stand up, you can't even see where the stoma is. So when managing all this stoma, you also need some convexity to help to press the surrounding skin to be more flattened out so that the stoma can be protruding in order to reduce the risk of leakage. So with the indication, you know, all these cases are not easy to manage, more so if the patient is quite with a deep skin fold, just like this patient here. When they sit up, you can't even see. So convexity, again, it will be very useful for the stoma that is in a deep skin fold. Okay, when you know the patient is needing convexity, but how do you assess to say that, oh, this is the correct convexity for the patient, because we are talking about optimization. So when optimized, you cannot just use one product to fit all the patient, because every patient is unique. They have got different skin abdominal plane. There may be different height of the stoma, the protrusion, or sometimes the skin surfaces may be different. So the best thing when you assess the need for convexity, first to remove the old pouching system and have a good look at the stoma, the surrounding skin, the protrusion, and many other things that you can observe. Yeah, look at the type of stoma. If it's a colostomy, you want to know whether the output is formed or is it watery. If it's ileostomy, naturally it will be watery. And look at the stoma protrusion, whether is it protruding or whether is it sunken in or whether is it flush, same level. The other thing that I mentioned once again, it is the stoma opening, because the stoma opening do make difference in managing a stoma patient, because it could be causing patient more problem if the opening it is not at the center. Yeah, and the effluent consistency is talking about whether the output is watery or not watery. If it's watery, all the more the reason to use convexity, because you need a very good seal. If it's not so watery, at least sometimes it doesn't sit below that easily. So you can still have some alternative, yeah. Then when we look at the abdominal tone, whether it is like what you see earlier, got a lot of skin fold, got the fat apron, or sometimes it is the skin surrounding the stoma is very badly damaged. So the best way to assess is to sit the patient up. Only when they sit up or they bend a little bit of their abdomen, then only you can see exactly where the skin fold. Otherwise, when they lying down flat, you hardly will see there is any skin fold. Yeah. So same goes to skin fold and creases. When sit up, then you can see much better. And the skin integrity, if the skin is already broken like this, you cannot afford to use something that is allowed the leakage to the side and causing the excoriation to become worse. So a good fitting appliance is very, very important for patient already with the skin excoriation. Yeah. And the appliances and accessories that the patient is currently using, that is important, because you know roughly what is useful for the patient, what is not useful, and what is the patient's preference. Sometimes they do not like one-piece system, they like two-piece system, or sometimes it's the other way around. Of course, we will also check with the patient how many days they can use the wafer, which means to say it is the usual wear time we want to know, so that we can gauge whether the convexity is suitable for them or not. And next, we will look at when the patient sit up, you can see the folds is so deep and you can hardly see the stoma. Yeah. Okay. Just now we talked about the one-piece system and two-piece system. Some patients will prefer a convex wafer that is one-piece system. It is also available in the two-piece system. I think it is more commonly you see the two-piece system convexity. Yeah, there's the skin barrier. Some are more rigid, some are more flexible. So you also have a choice, and look at the abdominal plane, whether is it firm or is it soft, in order to select the correct level of convexity and the correct firmness of the convexity appliance. Yeah. Now go to the next one. Okay, when you're selecting, nowadays there are more choices for the patient, because some companies, they actually have got different degree of convexity for the patient. If you look at this one, this is for very light convex. This is a moderate, and this one you can see the convexity is much more deeper. So if you look at the patient, depends on how deep the stoma is retracted, then you can assess what level of the convexity is required. Too much may not be comfortable for the patient. Too little may not be effective. Yeah. So the other thing will be the abdominal plane. If the patient have got very firm abdomen, you can use something that is soft. Yeah, soft is suitable for the patient who have got very firm abdomen. If the patient have got soft and flaccid abdomen, a lot of time nurses will find that using a firm convex appliance will be more suitable. Again, it is not every patient the same. Sometimes you have to look at individual patient, or you have to try it out in order for you to know which one is more suitable for patient and which one the patient feel more comfortable. Okay, other convexity items such as convex insert. This is a convex insert, and convex barrier ring, which is quite common nowadays. And some company have got barrier seal, and also ostomy belt. All these items will help in the convexity. For convex insert, I think not many of you have seen. I have used it before in the 1980s and 90s. That time we don't have those, we call the integrated convexity skin barrier. So at that time, we are using the convex insert. You can push the convex insert into the two-piece system, the flat two-piece system. You push it inside to make the flat skin barrier to protrude out to give some convexity. Yeah, it is not easy to put in and it is not easy to remove and reuse. Yeah, unlike now it is more easier. You can use the convex barrier ring, which is so easy. You can use one ring, you can use a double ring, yeah, or skin barrier seal. Yeah, belt is very useful for patients who have got sunken or flush stoma, and combining with the convex skin barrier, it is more effective. Yeah. Okay, now sometimes the patient may not have very deep skin fold, or maybe not so retracted. You can use something to replace the light convexity. Besides using the convex appliances, you can use the barrier seal, or you can use a barrier ring. You can even sometimes use some paste to level up, and that will be able to give you some light convexity. Yeah, even sometimes you can add the convex ring onto the back of the skin barrier and using for those patients who have got stoma slightly protruding, but the surrounding skin is sunken in. This is quite easy for a patient to manage on their own as well. And you may be thinking whether convex wafer can be used for just anyone, or is there any contraindication? In fact, this is a very interesting topic. There are a lot of literature that is contradictory. Some say yes, some say no. Generally, most literature says that there's no contraindication, but in some cases, we really have to use it with a lot of care, especially patients with early post-op. You do not want to exert more pressure onto the surrounding skin because it's still sore, or maybe sometimes can be swollen. So have to consider the other condition. In the picture here, the patient is having pyodermal gangrenosum. If the patient is having retracted stoma with the pyodermal gangrenosum, it is also not advisable to use because it might be pressing on the wound and you cannot remove the wafer every day to do the dressing. Yeah, and in some cases, I think more commonly you may see mucocutaneous separation like this one here or this one here. You also want to consider twice to use convexity. Yeah, if you can, you need to use some dressing to seal up, and then you use some skin barrier at the side, and then you use the skin, the one piece or two piece appliance on top. Yeah, still you can manage sometimes. Yeah. Also, when the patient having stoma necrosis, you may not want to add more pressure onto it because you do not know what happened inside. Maybe with the pressure, you may also aggravate the area to be more necrosis. Another condition is when the patient is having hernia. Hernia is not suitable to use convex because the hernia itself is already a bit like dome shape. If you are using another convex, the pressure will be much higher, and it does not really help. Yeah, most of the time hernia patient with flush stoma is more advisable to use a one-piece system. Yeah. Okay, now we look at other condition. I have got some of the cases, clinical cases to share with you. This is Madam A, 38 years. She has got low rectal cancer, and she got low anterior resection done, having a temporary ileostomy. And this was after she discharged. When she go back to hospital to remove the rod, after removal of the rod, the stoma sank down. So at first was a bit more protruding. This is sank down, but even sank down, it is still protruding. Unfortunately, the opening is below the skin. So the stoma opening pointing towards the skin, causing very frequently leaking. So patient have got skin exploration, very painful, and patient cried sometimes. She said when the husband changing for her, she says she cried. Then later on, she was actually one of the quorum members when she talked about it over one of the peer support group. So I went to see her at home. So I introduced her to use moldable convex wafer, and it works well for her after that, because it was from the everyday change, it was lasted about 5 days, and 2 weeks after about that 5 days, when she changed again, the skin have improved a lot. And these two picture was taken by the patient herself lah. So you can see the color of the pictures is different, but she was so happy. Now she's back to using the flat wafer. That means she can use the normal wafer now, because the area, all these all the separation here has healed up, only left the stoma, and the stoma opening is also pointing upward a little bit now. Yeah. Now case number 2 is Madam M. She's 35 years, colorectal cancer, ileostomy done, stoma is protruding moderately. Unfortunately, the stoma opening also at the skin level is on the left side line. Yeah. And this patient experienced frequent leakage. The skin redness, luckily it was not so badly excoriated. She was very careful. Whenever the output leak, she will change. So when I saw her skin redness, so we use also convex wafer, moldable convex, with some stoma adhesive powder, the paste, and then use the belt. And after that, she got no more leaking, and the patient managed the application on her own very well after that. So this is the case that I have managed. And case number 3, this is Madam T, 45 years. She's also colorectal cancer, ileostomy done. Stoma is well protruding. You can see it's very well protruding. Unfortunately, the surrounding skin is sunken in a bit. Yeah? And also, there is one more challenging area is the patient have got fistula at the 12 o'clock site, whereby the output just shoot out from here. It's like a fountain. Yeah, it's gushing out every now and then. Then the skin was badly excoriated, and the skin became discolored. Yeah. And the patient, another problem with the stoma is the stoma is very active. So the stoma is like pulling in, coming out. So that is what sometimes people say, the telescoping. The stoma can go in and out. These are patients, even though they have got protruding stoma, but it is always got leaking problem, because the stoma can retract it all the way in and then come out again. Yeah. So this patient used a 2-piece cut to fit wafer at first line. Yeah. After that, I suggested for her to use a moldable flat wafer, which she find much better, even though there is not convex, but she is using a seal, a stoma adhesive seal, to add on to some convexity, and it was able to manage well. For the skin area, she was using some duodenum extracting, and skin improved after 2 weeks. You can see after that, the patient is able to manage on her own already. Now, case number 4, this patient is Madam L, 52 years old. She has got cancer rectum, and she has got permanent stoma. She has got deep skin fold here, and the stoma is flush. You can see this is same level with the skin. Luckily her effluent was soft, not watery, and she has got she has to change her appliance very frequently. The skin is intact. She was using convex at that time also, but the convex was rather rigid for her, so she wanted to change to something that is more comfortable. Then she tried moldable convex wafer, and she find that the wafer actually more comfortable for her. But of course, the patient need a lot of accessory like stomatitis powder, paste, and belt. After that, she actually find that it is more comfortable and have a longer wear time. Okay, the next case. Oh, sorry. Okay, the other, this slide actually showing some of the cases that even though there is can use convexity, but if patient prefer something more comfortable, maybe you can actually use some alternative as well. Some of these cases I can use one-piece system for patient, and it manages well lah. Except all some of these are not my cases. I'm just showing you the cases can manage with one-piece system rather than convex wafer. Sometimes you just have to add the convex ring, that's all. The not convex ring, barrier ring. Yeah. Okay. Now that's also I found something that gives you a very simple way of how to match the skin barrier fit. Yeah. Like in situation whereby the stoma is protruding, the opening is in the center, and the peristoma skin is flat, then the patient can use a flat skin barrier. But the stoma, if the stoma is flush or the peristoma is uneven, then flat stoma with some convex barrier ring will be helpful, or the seal. If the stoma is flush, the abdomen is firm, or the peristoma skin uneven, they can use a soft convex skin barrier. Whereas if they have got the stoma that is retracted or in a deep skin crease or fold, a firm convex skin barrier will be more suitable for them. And of course, if the stoma retracted very deeply and the peristoma skin is uneven, a firm convex skin barrier with barrier ring or seal will be suitable for them. Now, there is something I just want to share with you, that I got this international consensus panel that was having a convention to discuss on the consensus-based guidance for the patient with convex that need convexity. So they have divided the consensus into 4 parts. One is about the product characteristic. What are the product characteristics that is suitable for patient, that is as a guide for nurses who is managing the patient with that need convex. Yeah. And some of the guidelines of patient's assessment and the indication for use of convexity, and also some outcomes. Yeah. Okay. About product characteristic is it says that some convex appliances are firm, some are soft, so you have to choose which one is more suitable. The belt also can enhance the convexity. It is in the consensus statement. Yeah, convexity can also be enhanced if it's placed near to the base. If the convex ring, you know, the patient have got the stoma is pointing to the skin, you have to put it very near to the skin. So that means you don't need to use additional seal over the lowest area. Then patient assessment, I have mentioned earlier, the best assessment is to sit the patient up, remove the old appliance, and also type of output, the stoma opening, the height of stoma, and also whether the stoma telescope or not, whether the location and the distal lumen. And also the other thing I think I have mentioned about abdominal tone, contour, patient using convexity must be reassessed from time to time. Yeah. So patient assessment of harmful effect if there's any ulceration or pain when the patient is using this, yeah, convexity. Okay, the next one will be the indication. I think I've mentioned earlier, and of course the outcome is they say in the consensus that the use of convexity can extend the wear time. So can extend wear time, meaning that it saves cost, yeah. And in conclusion, convexity is the remedy to a less ideal flush or retracted stoma with or without skin fold, especially when the effluent is very watery. Careful assessment and selection of the convex appliance and accessory will reduce the risk of leakage and prevent the skin expiration and prolong the wear time of the stoma appliances. So with that, I conclude my talk. Thank you.